Okay, Dr. Jennifer Locke. This is our third episode now together, and I'm always so thankful that you take the time to be able to not only educate listeners, but just everything that you're doing in this community. And I try to always set the stage by just explaining to listeners, what the goal is here. And before we hit record, I was mentioning how much I love having this podcast. I mean, trust me, this is a lot of time that I invest into this, that it's not that I don't, you know, that I don't see any income for. However, I feel it keeps me so much more up to date on the current research. It's almost like I feel like I'm doing mini courses all the time as I talk to my guests, because research is so important to be able to make change. And I get to talk to the people that are actually doing some of this research so that I feel that I'm up to date to talk to my clients about it. And it's been so nice having you in our community, because I think it just shows you have such a collaborative approach. You're always trying to bring in the current evidence and involve us as physiotherapists. So I really appreciate having your time and having you in our community. And for anybody that's listening, will you take the time to introduce a little bit about yourself? Kind of where you're located, your practice, and then let's get into the study that we're going to talk about today.
Well, Melissa, I think the feeling is mutual. I think that I really appreciate. I moved to Kelowna a couple of years ago, and I did some extra training in female urology and reconstructive urology before I came here. And I think before I came, there really wasn't any infrastructure for emphasis on female incontinence and female issues. And I think collaborating with you and some of the other pelvic floor physiotherapists and some of the other nurses, etc., has been really exciting because we can actually bring something to the patients, not only in Kelowna, but in interior health region. So I'm grateful to be here today. And yes, I'm a urologist in Kelowna and I work out of KGH Hospital. So I'm happy to see patients with any urologic issues, particularly with incontinence, and what we're going to talk about today, which is dyspareunia and genitourinary syndrome of menopause. So thank you.
Yeah, and just to start this off, I think we'll go into details a little bit more about that topic. But how this started is you sent out an email to a bunch of us physiotherapists in the region just saying, "Can you help me spread the awareness about this study that I believe it's you and one of your medical students are conducting?" So, will you tell a little bit first about I know that you do have other research projects too, but today, will you talk a little bit about, I know you're looking at the relationship between pelvic floor physiotherapy and dyspareunia, or pain with penetration, and GSM, or genitourinary syndrome of menopause. So will you talk a little bit about kind of how this came to be? Is it a special interest of yours? Is it something you're starting to see more and more about? Talk a little bit about why this study.
So that's a good question. In terms of my background, I'm a very curious person. And so I did my fellowship in female urology, but before I went to medical school, I actually did a PhD in cancer research. So I have a big interest in seeing what are some of the issues that our patients face and what are some of the questions that might actually be useful for our patients. And so I have paired with, I have 5 or 6 medical students that I work with on different projects. And my emphasis has really been on female urology for these projects. So this particular project is one that my medical student, Lauren, has really come up with to look at if there is a role of pelvic floor physiotherapy in helping the symptoms of women with dyspareunia, which, as you alluded to, is painful intercourse with penetration, or genitourinary syndrome of menopause, which is really a conglomerate of different symptoms related to postmenopausal tissue changes in the woman. And I think that the reason we do these studies is really to find ways that women that struggle with this can find options for them, because I think that they are quite limited today. So in terms of genitourinary syndrome of menopause, it's very common. It affects about 50 to 90% of women who are postmenopausal. That's huge. And so symptoms include vaginal dryness, pain with intercourse, difficulties with urinating or peeing, soreness, itchiness, burning, and pain in the area. And so a lot of women don't talk about it, but it is something that is quite prevalent out there.
And so right now, so this particular study, you are looking at that particular age group, I'm assuming. Is it, I want to know who qualifies for this study, and then let's talk a little bit more about some of the symptoms. So is it, again, I'm wondering, was this something that in your practice you were seeing so much of, or maybe that Lauren, your medical student, kind of was noticing this is a trend that I'm seeing, all these clients that are coming in with symptoms are also having some of these telltale signs. Will you talk a little bit about that? Is it just a theme that you see?
So in my clinical practice, as well as a gynecologist in Kelowna, we definitely see a lot of women. My referrals are usually for incontinence or urinary leakage. But coincidentally, we often see that women have this genitourinary syndrome of menopause, also thought of as what they call vaginal atrophy. I also see a lot of women with recurrent infections, and that plays a huge role in women that get infections. So because I saw this, we don't really have great treatment options for these poor women. And so I thought perhaps this is an area where we can find something for women with these symptoms. I think a lot of women probably just live life with these symptoms and move on, and they don't really seek help for them. And so, it's not to necessarily bring light to the fact you may have this, but if it is something that does affect you, there are options for you. And what are things that we might be able to develop in the future that can help you? And so my medical student really ran with it and has created this research project.
Yeah, because I would say that I can hear what you say when people say, they don't know that there are options. I think some of the things that I hear over and over again are, oh, it's part of aging. I'm just not sexually active anymore. Or, I've just stopped doing some of the activities that I love to do. I'm on constant antibiotics. I hear that all the time. I'm just on a constant
Right.
antibiotics. Doesn't really change the symptoms, but I have them all. As soon as I get symptoms, I'm supposed to start taking them. And then I think too, just going along with the incontinence, I think there's this misconception that incontinence equals the need for surgery. And so I'm sure that's what you were seeing, a lot of that. But then I think, yeah, like you alluded to, is we know now there are other options that I think aren't mainstream yet. And so I'm curious to know, you mentioned some of the symptoms that people will be experiencing. Um, when they have the genitourinary syndrome of menopause. And you notice that. And I'm curious to know what's making you tie in pelvic floor physiotherapy with this, because I know why you're tying this in, but I'm curious for the listener. They're coming to see a urologist. They have the symptoms of leaking. Maybe in your exam, you notice that they also have some of these other tissue changes. What's making you tie in the physiotherapy aspect of this study?
So I think, moving forward in medicine, I think it's important that patients that have issues take an active role and be preventative, because I think preventative medicine is crucial to taking care of yourself. And I think that pelvic floor physiotherapy would be something that is very important in that regard. So we know in terms of genitourinary syndrome of menopause or dyspareunia, that there are treatment options available, and they are, over the counter lubricants, vaginal laser therapies, and then the mainstream treatment is vaginal estrogens. So that can be in the form of a pessary, in the form of a ring, a tablet, a cream. There's different ways that we treat these symptoms. But what we know is that most women don't actually have satisfaction with these types of treatments available. Furthermore, some women can't tolerate them and other women can't use them because they've had a history of uterine cancer or breast cancer, or they're concerned because their mom and had a history of breast cancer. So although there are some treatments available, they're just not good enough for women with genitourinary syndrome of menopause and dyspareunia. So we really need to expand and find other options for these women. The reason why we're interested in pelvic floor physiotherapy, I think, is because we know there is a clear benefit of pelvic floor physiotherapy in improving women's incontinence, for example, stress urinary incontinence, but also in chronic pelvic pain. We know that the pelvic floor physiotherapy can actually improve the blood flow to the pelvis in the area by recruiting those muscles and working on that. And I'm sure you can talk about how that might work in general. But we know that there's good data to show that it already has beneficial effects in pain in the area, getting blood supply to the area, um, and incontinence. So I guess the question becomes, does it also have benefits, particularly in this genitourinary syndrome of menopause and dyspareunia? And that's a question we're asking in the hope that this can be a preventative or treatment option available to women with this that doesn't involve a surgery, doesn't involve taking a medication with side effects, those sorts of things. It's really minimal risk.
And I think I can kind of picture what that looks like. I think, and correct me if I'm wrong, but quite often, if this client happens to feel comfortable bringing this up maybe to their family doctor, and I think most people don't, they just suffer in silence. But if they happen to bring it up to their family doctor, I'm sure that's kind of where they're referred to you or another urologist. Like I mentioned, you do your testing, you do your assessment, and you lay out their options like you just mentioned based on the fact that you have these different tissue changes. These are your options. Some of the over-the-counter options: pelvic floor physiotherapy, hormone therapy, laser therapy. And I can picture that everybody's going to choose something different to start with. There's lots of different options. I see a lot of these people coming in, say, my urologist suggested that I see a physiotherapist. I did not want to. I wanted to do the least invasive therapy. I don't like medications. I don't like the idea of hormone therapy. I'd rather start here. And when they come in to see us, I would say, quite often their misconception is, I'm going to the physiotherapist to teach me Kegels. That's what the most common thing I think our clients assume that we're going to do, is we're going to teach them to simply strengthen their pelvic floor. But before we hit record, I explained a little bit more about, we have time. I think that's the one thing that, sometimes that's unique to our profession, is sometimes we have a bit more time. And, we ask a series of questions before someone even comes in to get the big picture around what, some of your peeing habits, some of your bowel movement habits. What's your trauma history? What kinds of things do you do for exercise? All sorts of questions that are going to give us an idea of your anxiety levels, your stress levels. Where do you tend to hold tension? How is your nervous system upregulated? All of those things. And then when they come in, I spend a lot of time just educating them about their anatomy. Okay, what did Dr. Locke tell you? Just so that I can kind of figure out, what do you understand about this? How do you understand that your pelvic floor is related? What did she suggest? Did she suggest you try some estrogen cream? How are you doing that? Show me where you're putting it, stuff like that. So I can, and show them on the model, so that they can understand their anatomy. And then quite often, because of these same tissue changes that you see, I find that, most people, their symptoms, especially when we're talking about incontinence here in my story, that they assume their pelvic floor is weak and that they're coming in to do strengthening. But the number of people that are holding so much tension in their muscles because of discomfort in their tissues. Right. So you assess the pelvic floor and explain to them, you're actually holding quite a bit of tension in these muscles. And they think, oh, wow, I thought it was weakness. But, sometimes we explain the weakness or the fatigue can be from holding tension all the time. Okay, well, then why is this person holding tension? Are they holding tension because they thought they were supposed to hold those muscles tight all the time? Maybe they've described that they are so uncomfortable from their underwear rubbing against their genitalia that's what creates the discomfort and holding the tension. But as you mentioned, there's a lot that we have to offer that isn't just related to tightening the pelvic floor muscles, but then being able to put that together with, given these tissue changes, what kinds of things can we do conservatively? But sometimes, and I often explain too, that no amount of muscle work or learning how to deal with stress in a different way or work on regulating your nervous system will necessarily change those tissues. So I think sometimes explaining that there's so many different things going on here, and that these are the things that I do think I can help with, but I can't change the quality of your tissues.
And
Right.
I think you hit it bang on that, like, the pelvic floor is such a dynamic process. So everything's related. If you have constipation, that can affect how your bladder works. If you have overactive bladder, sometimes you have a very tight pelvis, and that restricts you from fully emptying your bladder. And by not emptying it, you're triggered to go pee more often. At least that's what I explain to patients. And as you said, if you have pain in your genitalia and that's triggering you to keep a tight pelvis, then obviously that won't help you down the road either. So it's really getting patients to understand how the pelvis is so important in all of these processes, and finding ways to identify how to improve that, right? And that's like a huge role that as pelvic floor physiotherapists you play, and having the time to go through that and explain it and understand it is crucial. And you also alluded to the point that it's part of a treatment option, and we don't even know if it has a benefit in GSM, but I hypothesize it does. But it's with combination of other treatments. For example, to help the tissues, you can do vaginal estrogen, and it's fairly safe in most women, even if you've had sometimes a diagnosis of breast cancer. That depends on the aggressiveness, obviously. But also you can try things like vaginal hyaluronic acid and other methods. So it can be used in combination with different treatments.
Mm-hmm. And I, when I saw that, I thought that's so interesting, because I think a lot of people would think, oh, well, these tissue changes, how could the pelvic floor physio have an impact on that? But I look at that and I think, well, I mean, sometimes the impact, I think, could be through education, right? Just, it might not be that we're actually coming at this from a muscle point of view, but that again, that I have maybe the time to explain to you all of your different options, and maybe the education helps give you a little bit more context as to why Dr. Locke suggested the estrogen in the first place, right? Because I think sometimes they, right, and it might just be that it's not actually the changes in the muscle, but more that you have a better understanding of how your muscle is related to your tissues. Yeah. So I'm curious to know, will you explain, because when I have clients that come in that do fit that description, they're coming in, I can think of a lady off the top of my head that came in last week that was having some stress urinary incontinence, but she just described, I am uncomfortable all the time. When I walk, I'm uncomfortable. And she said, I am so itchy, but heaven forbid I scratch, because then I'm going to have open sores on my labia. And I have not been sexually active for a long time, so this was really affecting her life. And she didn't even want to talk to her doctor because she didn't want to use any hormone therapy. So there was a lot of education that went on here. And she's someone that I gave the information for this study because I thought this would be, she was really appreciative of the information. And I explained to her how something like a lubricant or a hormone therapy might be helpful, but that she needed to bring that up with her doctor. And so for listeners, I guess what I'm asking would be helpful is if you could talk a little bit more about what your study looks like, because I quite often give them the summary sheet that explains the bare minimum. But will you explain a little bit for those listening, because there'll be other therapists listening, there'll be other medical care providers that work with women that fit this description. Will you talk a little bit about some of what you're looking for and what that study will look like?
Well, so in terms of our study, we're really at the very infancy of looking at the role of pelvic floor physiotherapy in genitourinary syndrome of menopause. So there's different levels of studies. This is sort of just a survey study to look at how women do objectively and subjectively, but you can do large controlled trials, etc. Our main question is really to compare women who have symptoms. So that's a referral from a physiotherapist, a referral from a nurse, a referral from a doctor, or even self-referral if you know you have the symptoms of genitourinary syndrome, of menopause, dyspareunia, to our study to fill out a questionnaire. And the questionnaire basically looks at the degree of bother, of how bothersome it is to you, and whether or not you've done pelvic floor physiotherapy for another reason, and if it had any impact whatsoever. It's a pilot study to really see if there is a role for pelvic floor physiotherapy so that we can do larger studies. And in the context of this study, this is one study. We're also looking at the role of a virtual pelvic floor physiotherapy in incontinence, and we're looking at the role of medications in helping women improve their exercise and overactive bladder. And the point of all of these studies is to really look at if there's actually a role for these interventions, and they're pilot studies for bigger studies that can look at it in a more objective manner. So just to summarize, this is a small study to look. Takes about 30 minutes of a person's time to fill out questionnaires to look to see if you do have symptoms of genitourinary syndrome of menopause. And if you have or have not done pelvic floor physiotherapy, if it has played an important role or not. That's the question. That's the general question.
And will you speak a little bit to, because I think that, I mean, we hear as care providers, sometimes the frustration with how hard it is to seek help. And, you know, why did I have to wait so many years to hear about this? There's a reason that we do research or do studies to be able to gather information, to be able to create change, because the change in the healthcare system can't come without research. So will you speak a little bit to, like, what's the point in even doing these studies? Because I really don't think some people understand that. It's 30 minutes of your time, but what does that mean? Like the data you collect, what is that used for? What is the goal of it down the road?
So when I went to medical school, I was taught that we should always provide treatments for patients that have evidence-based. That means that, you know, if I offer you this drug, I can tell you that it will 90% chance improve your symptoms of X, Y, and Z. And so what I found in practice is actually that we don't have the research or the evidence to support a lot of the treatments we use. And we do what's called anecdotal medicine, where someone taught me that this is the best way to treat a patient, but there's no evidence for it. So there's gaps. And what we really want to do is provide what is the best option for patients. And in order to do that, we have to do these research studies. And the research studies, I know it takes time for participants to be involved in them, but I mean, you gain so much because you can help other people that have the same issues down the road if we can record if it is beneficial treatments, or you know, like that's how we advance cancer treatments. That's how we advance other fields, transplant medicine. And I think it's crucial that we do these studies in order for me to say to my patient, you know, look, we understand that pelvic floor physiotherapy does or does not have a role in genitourinary syndrome of menopause. And that really can give them the confidence that walk away saying, oh, it does or does not work for this. And so that's why I try and spend time doing these studies with the medical students to see if there is an actual benefit of these interventions.
Oh, so then in summary, if you are, because I often share these episodes with my clients. So if you're someone that's listening that has some, you know, you're in and around that perimenopausal, menopausal age, you're starting to notice different tissue changes, like we mentioned, dryness, itching, burning, vaginal pain, pain with penetrative intercourse, dryness, what else?
Troubles with voiding.
Yes, troubles with voiding, frequent infections, maybe stress incontinence, more urgency, pain, discomfort. Then, you know, I'll link the place where you can inquire about whether or not you'd be a candidate to participate in the questionnaire. or also if you treat clients who maybe are presenting to you with some of these symptoms, and then when you do an exam you suspect that they might be a candidate as well, please share the information, because the more participants the better, right? The better quality information that you gain.
That's right.
Any other parting messages, anything I didn't ask you about that you want to make sure that listeners get from this, Jen?
I think, I'm really excited to have moved to Kelowna because I think there's a real need to address women urology issues. I think I've received a lot of consultations for women that have been suffering with symptoms for many years, and a lot of them, it's not suffering; they just adapt and do other things, and that's fine. There's nothing wrong with that. But I'm trying to build a community group that will help raise awareness for women's health and urology in Kelowna and interior health. And I'm really working on that as a means to help women in general. So hopefully in the next couple of years, you'll see some of that come to fruition. And I think that I appreciate that people have taken time to listen to this podcast and your other podcasts, because it really helps not only disseminate knowledge to patients, but also show that we're really trying to find ways to help these women in the long term.
Yeah.
So thank you. Thanks for
Well,
putting the time in to do that.
like I said, I mean, I know how much work it is behind the scenes, time and energy it is to kind of create any change or make any forward momentum. So, yeah, and I appreciate your time too. So, thank you.
Well, thanks for having me.